Uh, so, so just quickly, essentially today we're going to go over the workflow orchestrator and some of the key aspects of this system, which is being put in place to distribute outpatient CT cases going forward, specifically the B-list cases, effectively across all sites. So thanks for joining today, and we'll just go over those things. So. What is Workflow Orchestrator? Essentially, is a system that was designed with Sectra to automatically distribute and balance outpatient B cases um, across the numbered B lists. So essentially, taking all of those cases that are done across all sites into a single repository, distributing those equally across all of those B lists, and allows us introduction of a new RVU system as well. Um, so the advantages of this workflow orchestrator, again, first and foremost, automates the distribution of those cases. So no longer are you going to have to distribute these cases to specific numbered B lists. They're just going to be designated as B, and the workflow orchestrator will do all the heavy lifting in terms of sending it to the correct numbered B list. Um, so this should reduce error from incorrect and erroneous assignments, really ensures an equal distribution of these cases across the numbered list, and it allows for us to introduce this relative value unit where different types of cases are assigned different relative values depending on how complex they are. Obviously, that was just too cumbersome to do manually, and expect you guys to actually, differentiate between a CT neck versus a CAP study and balance those lists, but the workflow orchestrator will allow us to do that now. So although you're already familiar with the workflow and most of the workflow is unchanged, just so that there's clarity on language that I'll use for the rest of the presentation, I just want to go quickly through the steps for assigning cases in CT. So again, most of this is unchanged from current workflow, but there are some key differences that I will highlight. So once the case is started in Epic, when assigning that performing physician tag on the scanner, and again, just to highlight, it's the performing physician tag that you're setting on the scanner. Instead of assigning to a specific numbered B list going forward after this go live, which is going to be Monday, next Monday, October 7th. So that performing physician tag will be set as just B, the designation letter B, without any specific number. The WFO, the workflow orchestrator, will then distribute those cases to the various B lists appropriately. For all other case types, VIR, high-res lung, head and spine, the tag for assigning these cases remains unchanged. So you set those exactly as you would now on the scanner using that performing physician tag. So similar to current practice, urgent outpatient cases are assigned in part based on whether the patient is going to be seen the same day for follow-up. So most of the existing assignment rules for these cases are again unchanged. The primary difference here being that for outpatient PE or dissection studies that don't have a same-day visit, these will now initially be assigned to B instead of ACI. So currently we set those cases to ACI and then change them to B when the patient or when the RAD has okayed the patient to go home because there's no acute findings. Now we will be setting those to B initially. The rest of the workflow in terms of contacting the radiologist to check the case, that remains the same. But again, initially those cases should be set as B, and then I'll go over some of the idiosyncrasies with that later in the talk. But that means that all the other types of urgent outpatient cases, P1 or P2 priority cases, urgent outpatient cases with same-day ED follow-up, those will remain as being assigned to ACI as the initial. It's just the outpatient PE and dissection studies without that same-day visit. Once the examination is obtained on the scanner, Same as the current workflow for urgent outpatient cases without same-day follow-up. ACI RAD should be contacted to determine the acuity of that case, and depending on that, either they'll be left as a B, which will be the majority of cases, or rarely, when there is an acute finding, the case will be reassigned to ACI, and then the ACI RAD will subsequently give the report and instructions on where the patient should go, and then the exam is completed. So completing the examination in Epic, so going from in progress to unread status, will automatically trigger the WFO for cases that have been designated as B for performing physician, and then those will be distributed. Notably, if a case has been completed in Epic with a performing physician tag anything other than B, so including if no performing physician was set, just a null tag, the WFO cannot be triggered. It will not trigger. And once that case is ended, there's no subsequent way to trigger that case into the WFO. So please take care and attention to setting that performing physician correctly initially. Now we've removed the need to check the list for which B list. You don't need to do that, but just make sure that if it's a B case, it's set to B. If it's whatever else it is, that it's set with that appropriate tag. So because again, WFO cannot be triggered once the case is ended, just pay close attention. But appreciating that obviously the CT department can be a very hectic and distracting environment. It's inevitable that occasionally this will occur. So I just want to go over what to do in the event that a case has been misassigned. And again, this will vary depending on whether the case has already been completed in Epic or whether it's still in progress. So first, let's go over what to do when a case actually has been already ended in Epic. And this will operate similar to what we currently do in present day workflow. So if it's a non-B list that has been misassigned, say a head and spine case, or a high-res lung has been set to the wrong designation or to no designation at all. For those cases, pretty much same as what we currently do in Sectra. You reassign the reading physician designation. So this is different from the performing physician, but the reading physician designation that you currently reassign, you do the exact same thing. Put in a comment in Sectra indicating that the reassignment has been performed, and that's it. Similarly, for a case B case that has been misassigned, once again the WFO cannot be triggered at this point once the case has been ended. Therefore, a specific numbered B list will need to be assigned manually. So this, exactly as with non-B cases, this will be done by changing the reading physician in Sectra, and then including a comment to indicate that reassignment. However, because the grids will no longer be sent out weekly with all the various B lists for each day, we're just going to have one single master backup B list, which will consist of a few B lists that are present on all days of the week. And cases will be sent to those lists. Misassigned cases will be sent to those lists with each site starting at a different number. So you can print this out and keep it by the workstations, and pretty much those assignments will be based on that backup grid. But again, this should be kind of a infrequent occurrence. So here's what that master backup assignment list will look like. And really the number of cases that need to be reassigned should ideally be kept at a minimum. So at most, any given list really should only ever receive 1 or 2 additional cases any given day from this. But this is what you can use to reassign those B list cases that have not been triggered into WFO because the case has already been ended. Just use this grid to assign those cases. So what about for cases that have not been yet ended in Epic? For these cases, the WFO can still be triggered if the performing physician tag is changed in Sectra before ending the case. So not the reading physician, this is going back to the performing physician. Currently, the technologist group does not have the ability to change performing physician. This will be changed for Go Live, and you will be able to update this, and I'll give you a step-by-step demonstration of this process on how to do this. Um, um, but really notably, this should be applied to all misassigned cases. Um, but really it's most important for B-list cases that have been misassigned to something else, or when a non-B-list case is misassigned to a B-list, just because that will determine if a WFO is triggered or not. For all other misassignments, say a VIR case was accidentally assigned to high-res lung, it's less mission critical that the performing physician be updated before the case is ended. But I think just for simplicity's sake, if there's been a misassignment and it's recognized before the case is ended, it's should be standard practice that we update the performing physician to the appropriate designation, and then if it's a B-level case, then that'll be dealt with by a workflow orchestrator. So this is how you go about updating that performing physician in Sectra. So I'll just show here on the slides first, and then maybe I'll do a quick run through just on Sectra itself. I just have to change the screen to do so. Up until now, again, technologists were prevented from changing this performing physician in Sectra, and as of Go Live, you will have this capability. So essentially, within the patient history jacket, you right-click the examination that's in progress, opens up the drop-down menu. Down at the bottom, you will see properties. You select properties. It'll open up a dialog box that has examination properties, request properties, patient properties. Examination properties tab will be open by default. And within that examination properties tab, you'll see performing physician in this first column. It'll show the designation of the performing physician that you set on the scanner in this box. So if it was initially set to ACI, but it's meant to be a B list, it'll show as ACI. You click edit. It'll open up this little sub dialog box, and it'll have the designation that you set on the scanner in the family name. If this needs to be reset to B, you just reset it to B, or whatever else it needs to be reset to. Click OK. Click Save in the bottom right corner, and that's it. So that'll reset the performing physician to whatever you've changed the tag to. The reading physician will remain unchanged initially until you actually complete the exam in Epic. Once the exam is completed in Epic, this reading physician, if it's a B-list case, will be triggered by the WFO and will give a specific number, group B8 or what have you, and if it's something else, that reading physician will be updated to match whatever the performing physician that you set was. So this pretty much just again discusses that workflow that applies to those outpatient cases, those urgent outpatient cases. So again, this same changing of performing physician workflow should apply also to those urgent outpatient PE and dissection cases. These will initially be set as B because most of these cases are negative and are going to remain on the B list. So to minimize your additional work, these will initially be set as B. For the few cases that do have positive findings, where the ACI RAD will then report that case, those will then be changed to ACI in Sectra following that performing physician workflow that I just discussed. So pretty much the rest of this just describes what we already usually do. Contact the radiologist by Sectra chat to notify them that case has been done and it needs to be checked. If they haven't gotten back to you within a reasonable amount of time, I know the prior documentation says 30 minutes, and I left it as is, but I think it's reasonable to reach out in a shorter period of time by phone if they haven't gotten back to you. And then depending on what instructions are given by the ACI RAD with regards to acuity, disposition, and whether or not they will be dictating the case, then complete the case based on those instructions. And this again just describes those same things pretty much as we are currently doing them, except with the notable exception that if the case does have acute findings, it will now be reset to ACI from the initial B list designation. The rest of this again remains the same, but just to quickly go over for all those other urgent outpatient cases. So urgent outpatient cases that have a same day ED or clinic follow-up, or for P1, P2 cases, those still will be designated as ACI at the performing physician on the scanner, and those will be dealt with in the same way that they usually are. So again, just to quickly summarize the changes from our current practice, there's only a few things that need to be highlighted. When assigning the outpatient B list cases, as opposed to setting a specific numbered B list on the scanner for performing physician, you're just going to be putting the letter B, and that's it. For misassigned cases where the case has not yet been ended in Epic, we're now going to be amending the performing physician based on those steps that I described in Sectra, and then completing the case in Epic. For misassigned B list cases where the case has already been ended, then we're just going to be amending the reading physician as opposed to the performing physician, as per that master backup reassignment grid. And then again, for the outpatient PE and dissection studies without the same day follow-up, those will initially be assigned to B performing physician rather than ACI, and then the workflow will flow from there. So that's pretty much it. If anybody has any questions or want any clarification, feel free to ask now. Otherwise, I'll just pull up